So it is my pleasure to introduce Nancy McGee, who's with us today. And I'd love to put this up just because it shows like how extensive Nancy's background is. But really, I'll just, so we can get to the meat of the matter, highlight a few things. Basically, Nancy is Senior Vice President for Health Policy and Public Affairs at Humanity. And really, she has been working in health policy and public payer strategy for years and years and years. Yeah, I hate to say decades because I'm counting things in decades myself now, which sounds fun and really isn't. But anyway, lots and lots of experience and vast subject matter expertise in health policy, public payers, market access, patient access solutions.
I'm a public health aficionado. I have a doctorate in public health. All I care about is public health all day long. But ultimately, if we can't get our innovations covered and paid for somehow, either through the insurance system, which is what we're going to talk about today, or through some other methodology, you could have like the world's greatest idea for a public, solving an unmet need, solving something that's critically important to a certain patient population. But if we can't find a channel to how it gets paid in one way, or whether it's through insurance or not, it's not going to get used. And there are tons of examples that could punch up that chapter about either phenomenal successes in how companies have navigated this successfully, or like super drama nastiness for when we didn't figure it out right. So I'm going to start with like this, like to get us in the mood. Let's have some drama. Okay. So when I started my career, I was an attorney and I worked here in Menlo Park. And at that time, the coolest thing in the world was a cardiac stent. And I was doing a lot of research and this name kept coming up, Macauer, like, who is this guy? Like, and then like, I finally met him and he's, as you guys know, like the sweetest, coolest guy, and super thoughtful. But so I went to work in-house as in-house counsel at a small device company here in Menlo Park. And the patient population for this device was the Medicare population. So we had a Medicare patient population. And the exciting thing about this innovation was it was taking a surgery done in the inpatient and it was moving it into the physician office, and it was a minimally invasive procedure. So why would you want to do that, 65-year-old patient?
It's a much lower risk procedure. You can also democratize access because it's lower skill required to do the procedure. Yeah,
and no like general anesthesia, right? And the risk of infection goes down, and all sorts, like this is like a good thing. So we were all excited about this device, and it had phenomenal clinical evidence. I got there right as we were waiting for our FDA clearance for our device, and I was working away on contracts and stuff. And the day that the FDA cleared the device, we took the company public, so that was exciting. The day that the device got cleared by the FDA, we loaded the device into my pickup truck and we drove to FedEx. And then we had champagne in the, like the, you know, it was like a great day. I remember this to this day. Okay, 30 days later, what do you think happened? The phone starts ringing. And like the receptionist is like picking up the phone, and we can hear like all the executives, we're a small device company, like could hear questions about Medicare and claim forms. And the receptionist was like, well, we don't have anybody like that or whatever. So what the problem was, we didn't even have a strategy for access. Basically, you know, we didn't have a reimbursement person. Somebody on the business side said, oh, well, the surgery is $30,000 inpatient. So let's just charge a fraction of that. Like we'll figure out some magic math, and that's what we'll charge for the device. And then, you know, doctors will figure out claim forms and stuff, and we don't need to deal with that or whatever. Well, of course we needed to figure all that stuff out. So we had no help for physicians to say, here's what you put on the claim form while we have a device that doesn't have a code. And here's we need to motivate Medicare carriers to cover and pay for this. So what happened? What do you think happened to the stock price? Down, you know, and we were just like way behind the curve. So this is like a subject where, again, like turn off your mind from like, how do we help patients? This is about the business of medicine and how do we get your super creative, wonderful ideas, which I've seen so many of over the years. How do we make sure that people can get it? We have to navigate this channel, or we need to decide we're not going to navigate this channel, we're going to do it some other way. So in the US, we have 3 payers that we need to know about. And you don't need to be the big market access expert, but you do need to know like a couple of little things. You need to know who the 3 payers are. So we covered Medicare. And the way that I remember that, this is simple. It's like we care for elderly people. That's how I remember that. Our second one is Medicaid. So that's low income adults, children, pregnant women, and disabled. And then our third one is what? Private, right? Okay. So each one of these things, they have different ways that they're funded. So Medicare is funded by the federal government. Medicaid is funded by the state and the federal government. And then private insurance, that's like private business, right? So if I work for Lumanity and Lynn works for Stanford, and let's pretend we both have Aetna, probably our plans are really different. Like Stanford has given Lynn this killer, awesome benefit, and maybe my employer doesn't give me as rich of a benefit, but we both have Aetna, but she has more access to more things than I do by virtue of what our employers have purchased. So why do you think, from a strategic perspective, we're so interested in Medicare? Why do you think that's? It's federally funded, so what does that mean? So it's a source of a lot of claims. You're right. But also because it is federally funded, we know how what codes are used, and these codes are replicated and used in the private payer system, but we also know how much they are paid for in the Medicare system. So we know at least a baseline when we're doing our study. We've got our cool innovation, right? We can look at either similarly situated devices or things that are kind of close, and we can guesstimate based on those payment rates what the payments are going to be. And so private insurers look to Medicare, and they generally do what Medicare does. So if we can focus in on Medicare, we're probably going to get a good baseline understanding of like what was the road to coverage, what are the codes that are used, and what are the payment amounts. So this graph just shows you, Medicare has the most claims filed, and that makes sense because it's an elderly population. They're having a lot of things done. But when we look at the US population, the biggest payer is private insurance world, and then it's actually Medicaid, and then it's Medicare. But Medicare is growing exactly for the reason from the back row of like baby boomers, it's getting bigger and bigger and bigger and bigger. Yes?
Medicare Advantage in the green or the blue?
Medicare Advantage on here is, I don't know if I called it out. I think I put it all into Medicare. So Medicare Advantage, so this is a great question. Let me go back one. Is Part C. So Medicare has 4 parts. So A is inpatient, B is physician office and outpatient, C is this thing called Medicare Advantage, which is a private payer who contracts to manage that population of Medicare patients, and they often have a richer benefit than standard Medicare. So for example, a lot of Medicare Advantage plans have vision and dental, whereas you can't get that in normal Medicare. And then Part D is the newest part of Medicare. It came around in 2003, and that's how seniors get orals and self-injectable drugs. So before that, seniors had to have a separate private plan to get oral and self-injectable drugs, which is just crazy, but that's the way it was. So let's talk about, so we know the 3 payers. This is like the presentation of 3s. And the reason we do 3s is people can usually remember 3 things. And when we get to the 4th thing, forget it. So the 3 things we're going to talk about are some core components. So we're going to talk about codes. Those are important because they explain what we're doing. We're going to talk about coverage, and that's when the insurance company says, yes, I'm going to cover for something because it has sufficient clinical evidence, and I don't want to review a claim by claim by claim. I want to be able to let my software, just get this patient through as quickly as possible. And then lastly, we're going to talk about payment. So we said that this is the business of medicine. So this is like the pipeline of how do we get, how do we get the doctor paid? How do we get the facility paid? The tricky thing here is payment changes by setting of care. So if you're in the inpatient setting and you do a procedure, and let's say you could do it in the outpatient setting, those are two different economic systems and you would get two radically different payments, okay? And then if you took something from the outpatient and you did it in the physician office, that's a third system. So one of the things we look at when we're doing a reimbursement assessment or a market access assessment for a technology that can choose a setting of care, we say, these are three economic systems. They work very differently. The first two are called prospective payment systems. So like when you go to the inpatient and you get your, you get a new knee, or you have I think in the book, it's a cardiac ablation. That's maybe the outpatient procedure. There's one payment you get for that. And if the patient is like healthy and you get them through the procedure quickly, the hospital probably makes money on that patient, and that is super. But if the patient is complex and has a lot of things going on and needs to stay in the hospital longer, they lose money on that patient. So as you're thinking about your procedure, you want to be thinking about which setting of care makes the most sense for my procedure, and what business story can I tell to the stakeholder if it's in the hospital about getting patients through faster or fewer infections, or improving the readmission rate. These are things you need to think about from a business perspective. Okay. So we're going to talk about codes. Codes are fascinating. So in the inpatient, I said there are these things called DRGs. Those are the payment buckets, but we look at procedure codes, which are ICD-10 codes, and they're all diagnoses, and your book does a good job explaining that. In the outpatient and in the physician office, we use CPT codes. And those codes are, interestingly, managed by the American Medical Association. It has nothing to do with the government. They're created through the American Medical Association. So in the book, there is a cartoon, right? I was interested because I was like, oh man, there's some drama, a cartoon on this chapter. And you see the little guy come out of the FDA, and he's got his FDA clearance, and then there's this gigantic building and it says reimbursement, and it's like this big scary building. And basically the thrust of that is to say that just because you get FDA clearance for your product, it doesn't mean you have coverage from the Medicare program. That's a totally different system. And the challenge that manufacturers have, and you'll hear a great case example shortly, is how to navigate that, either carrier by carrier by carrier, or trying to go to the national Medicare program to get it navigated. But when you think about your timeline for your product, you've got the clinical timeline is pretty clear. Like your FDA regulatory timeline is clear and mapped out. But the stuff about how long it takes for your device or your innovation to get actually covered and paid for, can be reliant on whether you need codes or not. And that will shift your timeline. But coverage going payer by payer can be super tricky. So the second part of coverage that's fun is just because you have a code, it doesn't mean it's going to get paid. So to grant payment, you need to have a coverage policy, and it usually specifies what codes will be used, what conditions are needed to have the procedure, and then these coverage policies vary by payer. So coverage is sort of the most complex piece, I think, of access, because it can differ between these payers. It can differ in the Medicare program. It's the trickiest piece, whereas a code is a code and a payment is a payment. So just to get to another level of difficulty, and this was not in your book. So we said that private payers contract with the Medicare program to manage patients. Okay, and that's the Medicare Advantage program, but we also just in general have carriers that manage Medicare patients under standard Medicare. And there are about, I want to say probably 30 of these Medicare contractors out there. So one strategy is to go to each one of those carriers, and they have a subset of states, and you say, here's my product, here's why it's important to your patient population, you should cover for it. And let's say they say, okay, we're going to cover for it in California. So then you take that California coverage policy and you go to Oregon and Washington, you go, like your neighbor, California is paying for this, you should pay for this too. And hopefully are motivating coverage policy. Now you can see this would take a long time, right? You're going, so why wouldn't you go to the national Medicare program building in Bethesda, Maryland, and knock on the door and say, can I please have a national coverage decision? So if you get a no from national CMS, that means all 50 states and all of the carriers can point to that decision and say, well, it's a no, and I'm not going to cover it until you reverse that national non-coverage decision. And that can mean a whole new clinical trial. So my advice to you and every client is never go get a national coverage decision. It is better to go state by state by state, because then you can at least say, hey, Florida has a huge Medicare population, they are covering, and it makes sense for these other states to follow suit. It takes time. It takes money. So you're thinking about your investment dollars, right? To fly around and talk to these payers and have these discussions. And it adds to your timeline. So what can trigger one of these coverage reviews? One of the ways that, so it could be price, or there could be a payment consideration. It could be clinical. Most often what it is the innovator has decided to use a code that hasn't been used in a long time, and they've gotten high physician uptake of this product, and suddenly this payer's software system, why are we getting billed this code all the time? And they pull it up and they're like, what is this? And why are we paying this out? And like, we're losing, where is this money going? So it's often, and then they say, well, is that the right, what is this new device? And does it really work? And that will trigger a coverage decision, like a look down into it. So when we think about codes and flying under the radar and seeing if it's really important that if you use an existing code, it really does read onto what you are doing. Our third thing, payment. And then we're also going to talk about copayment, and your book talks about copayment, and it's important. So for Medicare, Medicare will pay 80% of the patient's bill, and then 20% is the patient's responsibility. In most cases, most Americans have a supplemental insurance policy, and that takes care of the 20%, but you should be aware that some people don't have it. So when you're thinking about your patient population, if it is a patient population that, let's say, is financially needy and they typically don't have that, you're going to need to think about copays, because that could be a barrier to patient access, right, if they can't afford that copay. For private insurance, copay levels are different. So again, we gave the example of Lynn's Stanford policy and my Lumanity policy. Let's say it's Aetna. Because we have different plans, we could have very different copayment structures. So she could have a $5 copay, and mine might be like $1,000. It can be very, very different. And it's just important to think of from a patient perspective. Now, when we think about codes, and often this question comes up in this class, it's like, okay, this code reads on what I'm doing, but it pays $2. Like, this is not enough for my brand new cool innovation. And so what are the steps that I take to change that payment amount? It's extremely difficult to change the payment amount, because it was, that code was created through a study, and the book talks about relative value units and how payment rates get assigned. And the codes have been around for a while, so it's hard to get agreement to move a code up. It is not impossible, but it is very difficult. So it's something to think about in your strategy. Okay. In the book, we had this example, and this is just simply that example again of the atrial fibrillation. So the procedure is done, the physician has a set of codes, and they get paid, and that payment amount is around $1,200. And then you should also know the facility has a payment, and that payment amount is around $13,000. So when you're talking to physicians and hospitals, you need to know, like, oh, for the physician, like, this is the CPT code, and this is what you can expect the Medicare payment to be. And then when you're talking to that hospital person and you're saying, I need room in the budget so that you pay for this device, and this is the payment you're getting for the facility, so that they're aware of, like, what is that amount and what part of the pie are you trying to claim for your device. Okay, there's a reason why I left the practice of law and went into consulting and market access. Like my parents, when I did that, they were like, oh my God, we just paid for law school. Why did you go into consulting? And I said, because I think nobody understands this. And so it's probably like a good career move. And it has been because it's complicated, right? So advice is some of these rules change and are very nuanced. Go get a market access expert. I mean, I know you're not for this class, but when you are really going to do something, go get an expert because you're going to want to know these nuances. So what are the 6 things that your consultant needs to do? It's these 6 things. They need to give you a payer mix. So of our 3 payers, my patient population, what % is Medicare, what % is Medicaid, what % is private? And then you know which segment is really important to you. What setting of care should I do my procedure in? And do I have a choice? If I have a choice, what do those economics look like? What are the codes that are used? Are there existing coverage decisions that exist? Interviewing some Medicare medical directors who have retired, or interviewing some private payer medical directors to get their sense of your strategy and does it work, like interviewing those people and getting their feedback. And then there should be a summary at the end that we call recommendations of here is your path, here's what we recommend you do, here's how long we think it will take. And hopefully, if you want help, we can help you do it, right? So those are the 6 things you need. A really great strategy incorporates feedback. So really ensuring that we're tapping into key opinion leaders, that we've got a strong value proposition from a medical perspective, a clinical perspective. It's focused on evidence-based medicine and quality measures. All of these things will help you make that case to get investment. So it's important to get those points of feedback. All right, I'll quickly, so we made the point earlier in the back row about, we're getting this population of people where it's really going to burden the Medicare program. And this is why we're seeing policies. So the latest policy happened late last year. It's called the Inflation Reduction Act, and it has to do with drugs. And if you want to talk about drugs, we can do that. But it has to do with, all these people are entering the Medicare system, and how are we going to make it affordable? So we are looking at, from a policy perspective, of levers to make it more affordable. So one of the ways to do that in the Inflation Reduction Act is to negotiate drug prices, and that's a big deal. Why do we have health reform? It's because we need a way to cover and pay for things better. We need more cohesion between the systems. I think you've probably seen in your own studies and research that our system is highly fragmented. And so we're trying to find a way to make sure that people have access to innovation through insurance, through either Medicaid, the exchanges, or private insurance. But we're also trying to make sure that our system isn't so fragmented that we're spending more money than we should. So trying to align these systems and develop something called value-based care. So we're not paying for a volume of procedures, we're paying for the value of care through making sure we're paying for things appropriately and we're delivering care in the right setting of care. And just because somebody's having something done in the hospital and then goes into a doctor's office, we need to know what happened in the operating room, and that community-based physician who takes care of the patient from day to day needs to be aware of what happened in the surgery. We need linkages to make sure that we're taking care of people better. And that's the thesis of delivery reform. And hopefully we'll be paying for things with higher value instead of paying for things off a menu at a restaurant when you order a beer and a hamburger and fries. Instead, we want to pay for the value meal, right? That should be cheaper and faster and more efficient.